Now we have Dr. Gaurav LUTHRA, a master blaster and a high experienced ICL surgeon. And all to you, Gaurav.
Thank you, Sonu, and it's a privilege to be in your course. And Sonu has asked me to speak on managing phakic lens nightmares. And I wanted to start with this, obviously nightmarish situation with a phakic lens. So this patient was referred to me, was in fact came to me operated by a colleague who's well known to me. Both eyes were done very nicely. One eye was doing well. This one was having a good vault. Fellow eye was not doing well, the patient was not seeing well, but they had not been able to diagnose what is the problem. So when I did the OCT, clinically it was difficult to understand because the situation, it wasn't a very clear picture on the slit lamp. But when we did the OCT, we found that the ICL was sitting upside down. And this is not a new slide because now everybody's become very careful. This is from almost like 8-10 years back when they just started doing ICLs in their practice. They found that they could not diagnose this. So patient was with me about 15 or 20 days post-op, not seeing too well, about 6-18 types. And I saw that the ICL was upside down in one eye. So I told that patient to immediately get it explanted and if possible go back to his primary surgeon, otherwise I would help him. So patient came back to me about 5-6 days later after having the ICL explanted. But this is how it looked. It was a proper cataract formation and there was a fibrotic ring and there was a central clearing where the lens had given way. And it had become the cataract had kind of melted almost. So I had the difficult task of kind of retrieving whatever I could from this eye. And this is a nightmare situation. So one has to be extremely careful when implanting phakic lenses. Ideally on table, you should be sure that you've got your landmarks right and you've implanted the lens in the correct orientation. It's usually easy to see for an experienced surgeon, but even some experienced surgeons may miss the fact that the ICL opened up upside down unless they are extremely careful. Of course, intraoperative OCT has made a lot of difference and now we can actually see the vaults on intraoperative OCT, but first thing post-op day one should be to look for the vault on the slit lamp and maybe an OCT documentation is a great idea. So that would help. Now this patient, of course, we did the cataract surgery, patient did well. 6 months later went on to develop a detachment in that eye and that was operated and finally, patient was settled. Now this is another situation where I had a lady, 46 years old, who had been coming to me for almost 8-10 years with keratoconus and stable keratoconus, no cross-linking done, but had stabilized over the last 10 years, had very high astigmatism. As you can see, 4.5 diopters in the right eye, 3.5 diopters in the left eye, improving to 6.9 and happy with glasses. Wanted refractive surgery, kept coming to me for almost 10 years. When we did the topography, obviously there was keratoconus, but it had remained, even the topography was stable over the last few years. So we decided that we can take a chance of going with a phakic lens. The AC depth was about 3.01 here in the right eye, 2.92 in the other eye. We did some calculations using the OCOS and then also using the ASOCT based data. And there were two sizes being predicted. One was the 12.6 and the 13.2. Since it was a keratoconic eye, we thought that we might end up using a 12.6 because usually they have a falsely high axial or the anterior chamber depth. So we went ahead with the surgery and luckily we ordered two lenses, 12.6 and 13.2. And so it was a routine surgery. We implanted the ICL. This is a 12.6. And once that was in place, we went with the AIOCT and you can see that there is almost no vault. It's just about 50 to 100 microns. On the right side, it's not a very clear picture, but you can probably make out a little bit that the ICL is sitting somewhere here and this is the crystalline lens. So there's just about 50 microns between them. So obviously this ICL would not stay there. Now if we did not have access to an IOCT, we would have never known that this vault is solo except unless, on the next day or maybe post-operatively on the slit lamp. So luckily we had a second lens with us because we had been trying to decide between the 13.2 and the 12.6. So on table itself, we decided that we need to explant this lens and put in the 13.2. So we went ahead. And after this ICL is out, we implant the 13.2. And finally with that, we got a better vault. And you'll probably be able to appreciate that on the right side. It's not a very clear picture for some reason, but the vault was much better. post-op documentation showed about 330 microns in both the eyes. So both eyes eventually got a 13.2 and patient did well. Now this happened to us about 2 years back. And after that, what we started doing is then now we order 2 sizes for each patient. And on IOCT, we decide whether the vault is to our liking or not. If we find that the vault is either too high or too low, we can downsize or upsize the lens. So that has helped us give our patients a better result. Now this young lady was post-ICL almost 10 years. And during COVID times came to us with post-COVID vaccination, bilateral uveitis, and a very severe one at that with hypopion. Treated adequately, went lost to follow-up because she went back to the hills. Came back again 6 months later, with this time with again uveitis with intumescent cataracts in one eye, and the other eye also with a very significant cataract. Again, we ended up almost with an iris Bombay in one eye, so we did a laser iridotomy which expanded to become quite big. And finally, of course, the inflammation became quiet over a month or two. Then we took up the patient for surgery, but by this time this lens was very intumescent. So for cataract surgery, there's a pupil which is not going to dilate beyond this. There are some synechias, and there's an ICL sitting there. So ICL, phakic lens eyes don't do very well with inflammation. If they have inflammation, one has to treat them very aggressively. Otherwise, they tend to get complicated very fast. So if there's an attack of uveitis in a patient who has ICLs in situ, one must intervene. One must treat them adequately and promptly. And in some situations, if the inflammation is not settling down, it may be a good idea to even remove the phakic lens. So here under infusion, I am trying to get this ICL out of that smaller pupil. So I'm negotiating it out. And once I get one haptic out, then the other one, and then of course both of them. Now I'm going to stain this capsule under the ICL. I don't want to put in viscoelastic till I've stained the capsule nicely. So I go under the ICL and stain with trypan blue and get the ICL out. And now I want to, because it's a very intumescent cataract, I want to decompress this lens. So I'm going in with a 26 gauge needle on a 1 ml syringe. I will puncture it and try to aspirate whatever I can very quickly. So please keep watching, and then that's the plan. And the moment I touch it, it just goes into the Argentinian flag sign. Now it's of course a soft cataract, but you can imagine the kind of stress. It might have just ruptured on its own if I'd left it like that for some time. So I salvaged the situation here, and this patient was planned for a toric lens because this was a high astigmatism, but I think eventually we didn't put a toric lens. Fellow eye, we thought that this is a lesson to be learned, and we decided to go with a femto-assisted surgery. Fellow eye also had a flat vault with a fairly advanced cataract, and we went with the femtosecond laser here, and as it starts scanning, you'll be able to see that the laser does not detect the ICL very nicely. This is the ICL sitting over there, so the corneal parameters look nicely, but you can see that it's picking up the iris incorrectly. It's picking up the iris plane on the ICL plane, and it actually picks up the optic of the ICL as the pupil. So then you have to rearrange the landmarks so that it fires at the correct place, because otherwise your capsulotomy won't be perfect. So I've rearranged the anterior capsule lens and the posterior capsule landmarks properly, and then you can fire the laser. So this makes life much easier, and then now you have a rhexis in place. Most often the rhexis comes out well, sometimes it does not, and I'll just show you a case how it does not. After this, it's a cakewalk. You just get the ICL out, and then you go ahead with the cataract surgery. It's fairly straightforward. Now, this is another patient who was with phakic lens many years old, and I'll finish very quickly now. Underwent a VR surgery, and following the VR surgery, following the SOR, this lady developed a cataract and now needs a cataract surgery. So you can see the silicone oil bubbles here, and we thought that we will prefer a femto-assisted capsulotomy here, and went ahead with the usual way that I showed you. We are getting the landmarks right, and as always the ICL gets picked up like the pupil. So once I have all of them right, we fire correctly, get the ICL out. Now once the ICL is out, you have to just go ahead with the cataract surgery, but what we find is that the rhexis is not good. So you can see here that the rhexis is not complete. Now the reason why the rhexis is not complete is something we didn't know before this case. It was incomplete because of the silicon oil bubbles in the chamber. Silicon oil is not penetrated by the femtosecond laser. So when you have oil bubbles in the chamber, never use the femtosecond laser for your critical steps because they will not be able to go through the oil, or else you can wash out the silicon oil first and then use the femtosecond laser if you must. We did manage to get away because we had to complete the rexus and everything. But after that, we also had to deal with this bad plaque which had developed. And we literally had to peel it. You can see how tough it is. And I'm trying to make a plane with manual dissection. And you can see that I'll try to go on one side, then the other side. And because if I leave this here, I'll have to come back and do a YAG later on, or a primary capsulotomy. So I'm just getting under the plaque. You can see the stresses on the posterior capsule because if I pull too much, it will just lead to a zonular dehiscence. But I managed to create almost like a smile kind of a pocket. And I'm sure Sonu Goyal is liking this because he loves to dissect his smile planes. So I've created a smile-like dissection plane. And then I just remove it with a forceps, I think. So once I've done that, I'll just hold this. Then I keep peeling from one side, then from the other side. And eventually, without having a break in the posterior capsule, I'm able to get that plaque out. So with that, I'll stop. Thank you so much.
Thank you, Gaurav, for that wonderful sets of nightmares. I think very wonderfully elaborated. Just a quick question by the time we have Kamal on the stage. What's the lowest vault that you would like to explant if you have a surprise? And
so if it's a toric ICL, I will definitely have less tolerance for a low vault, maybe anything below 100. Now, if it's a toric ICL and sitting right, it's not rotating, I will let it be even with a very low vault, maybe 100 or even say 70, 80 microns. Because I have a few patients on follow-up now who've not gone on to develop any cataract even after 5 years. We had offered them an exchange, but patient is doing well, he's 6'6", unaided. Eventually, of course, there's a chance he will. So it's a very difficult decision, but you have to discuss with the patient and give both the options to the patient and tell them that, an exchange might be beneficial to you. But I've been in a funny situation. There's a patient where I had a patient with about 50, 60 microns, and I told them that we'll do an exchange. Now, I upsized by only one step, which means that from a 12.6, I went to a 13.2, and I don't like to use the bigger sized star lens. For this, even after the exchange, the vault remained at about 80 microns. So a patient asked me that, why did you exchange my lens when my vault is going to remain the same? Now, this is probably because of peripheral zonular issues, right? But eventually, so frankly, if the lens, I'll keep these patients on close follow-up, like maybe every month or two for initial things. If I start seeing some early cataractus change, for one patient, I recently did that. 1 month down the line, we started noticing some very early changes. I've gone ahead and, done the ICL exchange, but this time I upsized by 2.
thanks, Gaurav, for enlightening us.